Hey everyone, Nathan Long here, president of Saybrook University. Welcome to another episode of Saybrook Insights. As a kid, I got the opportunity to watch my dad in action as a mental health worker and administrator. Now, while he wasn't a clinician per se, he was surrounded by psychologists, social workers, and counselors. Throughout his time, he would occasionally bring me along to the office, or in a couple of instances to the mental health hospital of Ohio, where I would tag along. And while he did his work, I would amuse myself in an office, finding myself listening to the sights and sounds around me, including the people, most of them patients, but also physicians, psychiatrists, and the like. During these times, I learned many interesting things about mental health illness. My dad believed in the people he served, and hearing his approach to supporting them along with their medical team was really, truly fascinating, especially back then in the 80s. There was still a lot of unknowns, as we kind of learned from our interview today, that there are still many unknowns. During one of our visits to the hospital, we had run into one of the patients who was in a particularly fragile state. After we got off the elevator and settled into an office, my dad explained that this man was diagnosed with schizophrenia. The gentleman was having hallucinations at the time, was presenting as a superhero, etc. And I was scared, but also somewhat curious about what was going on here. This stuck with me for years, and later we would have someone close to our own family diagnosed with schizophrenia. And this was not too far from the time when I had gone with my dad to that hospital. Back in the 80s, as I mentioned earlier, while there was certainly knowledge about the diagnosis, my recollection at the time was that little was actually known about the disorder itself in terms of how it truly affected the brain, how and when it would manifest, and if there was ever hope for some form of recovery. Fast forward 40 years, and there is much more that we know about the illness, treatment regimens, and as importantly, how schizophrenia shows up in the brain through brain studies. And yet, as our guest talks about here in just a few moments, we still don't know enough. And we don't know enough because there's many different facets and factors that go into this. So enter in Dr. Michael Sakuma. He's a faculty member in our Department of Humanistic Clinical Psychology here at Saybrook University. Dr. Sakuma's career has spanned a couple of decades, and part of his education is in the area of schizophrenia, having completed research at the University of Oxford and elsewhere on longitudinal changes to the brain in those who had a diagnosis of schizophrenia. Along with covering this, we get just into the topic of speciesism and mindfulness and sleep. But Dr. Sakuma, we could have talked for probably 2 or 3 hours. So we're going to bring him back and have him talk more about those topics that he's both researching and writing about today and working with students on. I was curious how he came to study all of these areas, what he's discovered, and how, as a mental health practitioner, he sees the future of mental health in the United States. All right, so let's get to it with Dr. Michael Sakuma. Dr. Michael Sakuma, thank you so much for joining us today on Saybrook Insights. Before we get started, tell us a bit about yourself. This is sort of the role for every guest that we go through, and you're no different. So we want you to talk a little bit about your personal history, how you got to Saybrook, all that good stuff.
Well, personally, gee, you open with a really open-ended question. Let's see. Well, I got a Ph.D. in biopsychology actually back in the, I won't actually tell you when I got it. It was in the 90s. I decided that that I really wanted to work with people, and that research really was not, I was being trained to be a research psychologist. And so I respecialized in clinical psychology and then got jobs in academia for the past 20 something years doing clinical psychology. And I ended up at Saybrook. They say saving the best for last. It's a real honor to kind of be in this type of program that encapsulates really my interests over my whole career in terms of humanism and existentialism.
That's great. Well, as I was doing some digging into your background, which was really super fascinating, I was reflecting on my own background As a young boy, my dad was a mental health administrator and worker, had supervised social workers, counselors, psychologists, and supported them in the work they did. And it was at that time I became quite aware of schizophrenia, and I was really, really pleased to see some of the work you had been doing with a lot of colleagues back in the 90s. And it dawned on me that, here I have you right here to talk about a whole host of things, of course, over the 45 minutes. But one of those that I'd like to dig into for a minute, based on your background and experience, is schizophrenia. And, sort of kind of covering the gamut here in the short time we have. So maybe you could speak to our audience a bit about what exactly is schizophrenia, and then maybe we can get into your research and the work that you did back in the day.
Well, schizophrenia is really this insidious disease that it just affects the whole person. And when you go back to the traditional conceptualization of schizophrenia, literally it means split mind, right? And that's where the popular misconception of it being kind of what we would consider multiple personality comes from, of having splits in that mind. But really what it means is your thoughts are kind of split apart, your emotions are split from your thoughts, and so there's just a kind of debilitating, what's the word I'm looking for? It just leads to a bunch of problems in interacting. Now, it's a controversial disorder because, like the group that I worked with believed that it was a brain disorder, and that has been one really strong school of thought for many years. And then there's an anti-psychiatrist movement who believe that it's actually kind of a societal thing and it's based on a problem in living versus an actual disorder. And so, ultimately we're still trying to figure out kind of exactly what it is. I know that might not be a satisfying answer, but ultimately, it's at least from the clinical psychology realm, it's about getting people help and getting them support, because what ends up happening is they end up moving away from people emotionally, and their lives become very difficult.
Interesting, interesting. So, talk about those two movements for a minute. I think we have to unpack a bit of that. So, there's those who are talking about this being a brain disorder, and then there are those who are talking about this being something societally related. So, the nature nurture kind of the nature nurture poles, if you will, of the discussion. Maybe let's take that second part first. How is it that this would solely be in the realm of the social? And maybe I'm miscategorizing that, but I'm a little perplexed by that.
hmm Well, I think it was kind of used by two theorists pop into my head. Thomas Saz, who just recently passed away about a year or two ago, and another theorist named R.D. Laing, who was kind of big in the 80s. And both of those people, just kind of theorists, they focused on the fact that abnormality in and of itself is just a societal it's societal norm violation in many ways, and so people are acting deviantly from a societal norm, and norms are kind of arbitrary, and norms change over time. And so, for example, there really aren't symptoms that are universally problematic. So, as an example, like hallucinations might be normal in some culture where you might have a doctor who communes with spirits and so on, and so within that culture it becomes a normal thing to talk in voices and to speak to the netherworld and so on. And even psychologists like Carl Jung believed that schizophrenia really was an interest, and I'm sure you're familiar with Carl Jung pretty intimately, perhaps. But his concept of the collective unconscious was really a person going into that realm and communing with other people in a way that actually was quite normal, different than, say, you and I communing out here in this other world.
Interesting, interesting. So, we got to go down this road a little bit more.
I'm not saying I necessarily believe it. I mean, I do believe that abnormality is a very difficult thing to slice and conceptualize, considering the fact that, there are diagnoses that we have that were that were abnormal 30 years ago and now are considered to be, normal variation of behavior. So I'm not suggesting that schizophrenia is necessarily going to get there, but I think like any disorder, it's overdiagnosed and it's certainly used in a pathologizing way. In it's kind of like the shorthand. If somebody is acting strangely, then they're,
They're schizophrenic, yeah.
yeah, it's become the kind of poster child of mental illness, and that's why I think that the anti-psychiatry group had kind of latched onto it as being like, well, if that's true, and there's a famous case of a famous study in the 70s, a guy named Rosenthal, he did a study where he basically had volunteers voluntarily go into a mental hospital and basically they had to report one symptom, that they heard a voice say thud, and so that's all they told the person who was intaking. They acted normally in other ways, and the study was, how long does it take to get out of that hospital? And what they found was that there was great variability in how it was diagnosed, and there was great variability with respect to how long it took people to get out. And so those types of studies are taken as as evidence that this notion of schizophrenia is not as hard and fast as we would like to make it, and that when you're dealing with problems in behavior, and and oftentimes, when there are problems in behavior and we're treating it biologically and medically, there's a potential of a problem.
Yeah, for sure. And I guess it would kind of raises a question in terms of on the flip side. So, I remember a very close acquaintance with our family was diagnosed schizophrenic. And that individual went through a number of drug regimens over the course of their time. And no one could figure out for certain if the drugs had an impact or if the disease, if we're calling it that, had run its course. And I don't think the doctors, the psychiatrists, really could pinpoint with any accuracy whether the medication was having an effect. It was dulling the senses of the individual. It was, creating a more normalized experience for those around them. For what we would call like a non-abnormal experience for their family and friends. But as my dad and I talked about this not too long ago, one has to wonder, is the medication doing it, or is this some other sort of phenomenon? And it's interesting you bring up the anti-psychiatry movement in relation to this. And I wonder, do we have any insights on whether medication does truly treat schizophrenia? And I'm assuming here in our discussion that you might have some ideas on that, or if you kind of sit in the middle on this, or where you stand on that.
Well, my understanding is, and not being a medical doctor, obviously I can't speak definitively on it, but my understanding is that it's about symptom management. You're not actually uh, treating anything the same way that if you're taking aspirin with a brain tumor, you're not treating the brain tumor. And so I think that the medication can stabilize people, and it is it has been life changing for people. So I can't dismiss it as being um, non-important or misguided or something. But I think that, and perhaps because I am not a psychiatrist, I'm a psychologist. Um, there's always caution in a culture like ours that goes for, kind of medical interventions before kind of psychological interventions, interventions that are less invasive and Well, I mean, that's the word I'm looking for, less invasive. Another case that I'll just talk about is ADHD, which again is another controversial diagnosis, but you have kids that are oftentimes diagnosed. There's no real like set way to diagnose. There's a checklist, but there's no test that you can actually give for it. And there are some people in the field who believe that it's just kind of medication management for teachers to try to like and parents to help them function. So at any rate, it is a very complicated issue, but if I can give a plug for psychology and psychotherapy, it's about, it's about especially the humanistic side of it. It's about kind of connecting with people. And I will just say this one thing, since we were talking about schizophrenia, there was a movement in the end of the 1700s, 1800s, where you had mental institutions rising up, and you had basically a very politically motivated desire to get the quote undesirables of society out of the streets into these places. And so, as we all probably know, they were notoriously people were treated really horribly in those institutions.
Oh, terribly, yeah.
And so there came to be a type of treatment that emerged called moral therapy, where basically the idea was to treat these people like humans and to kind of connect with them and to get in touch with, to show respect to them and to listen to them and the types of things that we consider to be actual psychotherapy today. And what you found is that it actually worked. The problem is that it wasn't maintained because it costs too much money to do it on an individual basis. And of course, after a while, we no longer have to worry about institutions because they have been kind of disbanded. But um, but ultimately, I guess what I'm trying to say is that that showed that being kind to people with severe mental illness actually it can be very helpful. And a psychologist named Sullivan actually developed a similar type of interpersonal therapy for schizophrenia. And his is really the only type of psychotherapy that I know of that has actually been shown to be helpful with people with schizophrenia.
Interesting, interesting. So, boy, we could go down two different pathways here on the mental health hospitals of yesteryear and talk about where they sit now. I mean, I think there's an interesting path for us to follow on there. Maybe let's put a pin in that and come back to it because I really would like to talk about that in relationship to severe mental illness. But in terms of what you're talking about with the moral therapy of the 18th and 19th century and kind of where we've evolved to with more, uh, you know, drug therapy, pharmacological therapy, and some other maybe a little bit of humanistic or just general psychotherapy embedded within. What is a family to do nowadays in terms of treatment? And if they were to go in a more humanistically oriented direction, what would that look like from your perspective? If someone was diagnosed schizophrenic or another severe mental disorder.
That's a really interesting question. Just because, the way in which the field has gone is that if somebody has what is deemed to be a significant, severe, mental illness, if we want to use that term, um, medication is kind of is the first line of treatment.
It's a go-to, yeah.
I actually used to work with somebody here at Stony Brook who believed that ECT was the first line of treatment, and believe it or not, electroshock therapy is used quite a bit all over the country, and deemed to be a viable treatment for depression that is intractable, or bipolar disorder, or I think schizophrenia. But for me, that oftentimes, and especially since and people don't like to necessarily hear this or think about it, but we don't really know how a lot of these medications work. We know the mechanism of dopamine and blocking reuptake and so on, but we don't know how that converts to lucid thought, right? And coherent, cohesive thought. And so to me, that whole area is kind of like pounding a TV. I'm gonna show my age in the days when we used to have TVs that were thick enough to pound. Pounding it, pounding a TV with your fist because it's like you can't get reception on it, and hoping that it kind of clears up. And that is in some ways a lot of the treatment. Now, granted, I'm gonna say that. That's one side of me, and that's the more critical academic side of me. The other side is saying that will say that these science is wonderful in that it's self-correcting, and that we over time we may not be in a perfect place now, but I trust science as a way to figure things out, and we just aren't there yet. And so in the meantime, um, you know, understanding that that the people who are manifesting these behaviors are scared. I've talked with many clients or patients who they didn't really want to lose their hallucinations because they were their only friends that they had. And so, I think that especially because the way in which popular culture treats uh, schizophrenia is that we're afraid of people. But the reality of the situation is that people with schizophrenia are rarely violent and are safe. And so figuring out how to relate to them, to get in touch with the piece that's actually there, because the piece that you may be interacting with is, they're hurting.
Yeah, for sure. And their families are desperate to find a way, usually, to find a way to alleviate not only their pain, the individual's pain, but their struggle to connect and relate and figure that out, along with helping them achieve a more balanced life, a life that they can feel productive and fruitful in as well. So that's very interesting. So yeah, I won't push too much further on this because, as you said, I think the go to the primary focus is really around the medication and the regimen there. And it sounds like, from your perspective, the humanistic approach, let's say, we're going to try everything except medication right now, and then we'll see where we get to, or maybe in combination with pharmacotherapy. What would that look like from a practice point of view? I realize every individual is different, so every therapist is going to come into this with a different lens and a different approach, and certainly each individual presenting with schizophrenic symptoms uh, will be different. So, any thoughts on that?
Well, I would agree with you that having kind of co-joint therapy with, kind of medication as one arm and kind of more talking therapy, psychotherapy as another arm is going to be really, really important. And the talking therapy, I think, it's hard to make a generalization because people with schizophrenia are not just one type of person. And so it can't be a one size fits all. We should be doing this with this type of person. But I do believe that because of misconceptions in our society, and because of the fear and the feelings that these people probably have, I think that working on destigmatizing the the disorder, I think, is really, really key. Because what ends up happening a lot of times is that because of the stigma, people don't want to have it, and they feel like they start taking medicine, and the symptoms go away, so then they don't want to have it, so then they stop taking the medicine, and then it comes back. But if you can destigmatize, then the person can understand that it can be thought of as just kind of like a variation in how it doesn't matter how we present. The kind of analogy that I always draw, just because for me, I've been wearing glasses since I was 3 years old, and that's my variation on the one of my variations on the human condition. And so having people understand that their variation is not, it's not that everybody is normal and I'm abnormal, is really kind of key in helping people accept the things that may help them, and then, kind of gain strength and support to be able to maybe, I don't think that people necessarily need to take medication their whole life, but certainly it's needed to stabilize and to, once somebody has support and once somebody has other aspects, then, I think schizophrenia tends to run by they call it the rule of thirds, like a third kind of get better and don't need any kind of medication. A third, they're really debilitated, and then you have a third that's kind of goes back and forth their whole lives.
We were observing this in terms of my dad was bringing up the fact that a lot of the patients that he knew, I don't know if this is the fourth or if this is they get better, where that fits in here.
Yeah, that's one of the thirds. Yeah, well, they get better.
That's one of the thirds. It's either one of these two. So it was presenting symptoms for years and years and going through treatment, and then it was just sort of this move to a flat affect. It was almost as though they kind of got into this rhythm. And a lot of the folks that he worked with, and again, he wasn't a therapist as you were, but the individuals that he worked with, who worked with these individuals over time, they saw that flat affectation occur, and I'm not sure where that fits into all of this getting better, or to your point, maybe there's something else that's happening with that individual socially or biologically. I have no idea.
And we're still trying to figure it out. Ultimately, schizophrenia, like a lot of our disorders, are kind of an umbrella term to to conceptualize a lot of disparate syndromes that kind of have a common commonalities, right? And that's one of the reasons why I decided to kind of leave that area, because I kind of felt like it's a lot of work to do a study. And if I'm not really fully believing that somebody who's been diagnosed with schizophrenia is a homogeneous group, it's why I moved away from that. One of the reasons.
Because you were doing substantial brain imaging research, if I understood that correctly, right, at the University of Oxford. I'd like to move into some different territory in just a minute, but maybe speak to our audience about that, because I thought it was both fascinating and you did take a pretty dramatic turn into some different spaces. So if you don't mind speaking to that, that'd be great.
So as part of my degree, I was working in a laboratory that was involved with at the time, it was the longest or the largest longitudinal study of schizophrenia that had ever been attempted. And this is in the 90s. And so I came in roughly around year 6 or year 7 of a 10-year project where you're collecting MRI data to see if there's progressive brain change over time. Again, the idea is that maybe schizophrenia is something that where you can see the brain actually changing, such that over time maybe somebody develops the flat affect because of the brain having changed. And so what ended up happening was I graduated and I was working in that lab, and we were affiliated with a lab in Oxford, and I worked with one of the actually preeminent researchers in schizophrenia research. His name is Tim Crow, and he actually was the person who coined, if you're familiar at all with the type 1 versus type 2 schizophrenia categorization, he coined it. But at any rate, what we were focused on was the language disturbance that you see sometimes in schizophrenia. Now, of course, thought disturbance is kind of the paramount symptom, right? But how do you know what somebody's thinking? By their language. And so the idea was that perhaps schizophrenia was associated with changes in our language areas. And specifically, what we knew, or what we know, is that the brain is asymmetrical. like in most people, language functions. Of course, language is distributed over the whole brain, but most people take the shorthand that language is in the left side of the brain. And when you take a look at the left side of the brain, there's an area near Wernicke's area, which is kind of like clinically that's the speech area. From a neuroanatomical standpoint, that's called the planum temporale. And so it's a temporal plane. And what you find is that it's bigger on the left side than on the right side. And so people believe that that has some special place in language because when you destroy that area, people can't speak anymore. And so the study really was about, or the series of studies was about measuring that particular area over time to see if, in fact, that area was degrading. One of the problems in talking about this stuff with me is that I actually left that area, and because of that, I have kind of a critical view of the area, and I don't want to be dismissive of it or anything, just because there's a lot of great stuff there. But it is really hard to determine brain change, especially when people are taking medication, and you don't know if this is an issue that's being caused by the medication or an issue that is, just a disorder that they have that leads to a certain degeneration. Most people develop schizophrenia when they're about 18, 19 years old. If, maybe a gene kicks in at that time. We don't know yet.
I might have to fly up to see you and then just sit down and pick your brain on this one for hours. This is fascinating. To your point, I mean, from a core research point of view, I think our grad students at Saybrook would appreciate this conversation even from a research terminology. I mean, the correlation piece related to the variables that are involved here and how they interplay with, medication and, how were those sorted out from an experimental design perspective, what that looked like kind of long term, and could you really draw viable conclusions based on the data? I mean, that's all fascinating information, and probably it sounds like what you're saying is that, and I don't want to put words in your mouth, that you may have had a few doubts here and there about the plausibility of some of the results happening potentially there or occurring.
How should I frame this? I there were a few different reasons, but that certainly was one of my concerns was the heterogeneity of the disorder as I saw it. Another piece, and I'll just from a methodological standpoint, I think this is kind of interesting. Technology changes over time.
Yeah, yeah, yeah.
So the thing is that if you want to keep things standard, then you have to keep doing MRIs the way they did it in 1984. And in 1994, technology had improved a great.
Way different. Yes.
So you're stuck with 1984 technology to be able to understand all of that stuff. And so my belief in some ways was that the error that you would find in a slice from 1984 was greater than the amount of change that you might see. So, and I think that, I think this kind of dovetails back into, a discussion in some ways about humanism, because I do believe that we're seduced by this kind of biological model that everything is kind of mechanical and that we can just look at an area of the brain and know what is the cause of somebody's issue. And I have come to the conclusion that it's a lot more complicated than that, and that the way in is maybe to relate to the person and the person inside.
All very fascinating and a truly interesting perspective you bring to this discussion. Thank you for sharing so much of that background. You're into new stuff too, right? I mean,
Yeah,
you're in a whole different world of mindfulness and sleep.
I am.
Maybe talk to us a bit about what got you into that, and you talked a little bit about changing course on your research and agenda. So, why sleep and mindfulness, and where is it now for you?
It's interesting actually because I think I need to update my bio because sleep has always been a fascination to me. I've had a kind of a lifelong sleep issue, and so that became the kind of what is the term for when you do research? Me search, right? It is it became kind of a way in which I learned to understand myself, and also as a biopsychologist was able to work in some sleep labs and um, you know pick up some skills that I think have been useful, life skills, over time. But my real research interest at the moment is actually in it's more animal related. I have kind of come 360 in some ways, well 180 actually, by initially, my master's degree was in a laboratory where we were creating we were mapping the auditory system in guinea pigs. We picked different animals to use to help conceptualize like the systems that are similar to us. They use cats for our visual system and guinea pigs for our auditory system. And so I was involved in that type of research, and then somewhere along the line in my 30s, well, okay, I'm going to credit my wife on this. Um, I became vegan, and along with that came a whole awakening of kind of this notion that animals are not here for us, they're here with us. And this is kind of ties into my existential bent. And I don't consume anything with animal products now because I firmly believe in that. And so, what I'm interested in, and by the way, I just joined the Saybrook Animal group. We're conceptualizing a name, but you have a bunch of like-minded people here who really love animals and want to explore that a little bit. And for me, I'm really interested in understanding the complicated nature that we have with animals. Animals are kind of like somewhere in between a possession and a family member.
Yeah, yeah, that's a great way to put it.
Yeah, and so it's an interesting place, and then it's also in some ways a denial of the fact that humans are animals too. And in many ways, I think that leads to some of the problems that we have in society today.
Interesting. So, totally focused on animals in your research, your work right now. Is that fair to say?
Yeah, I am focused on creating at the previous school where I just came from. I had created a group for students who are interested in speciesism. It's a social justice program, and so that's the kind of thing I'm interested in bringing to Saybrook. I've only been here now for 2 years, but I'm getting to the point where I can actually start actively doing some research, and I'm looking for like-minded students to actually get involved with me.
Well, so if any of those like minded students are out there listening to this program, Dr. Michael Sakuma
Give
is
me a
your
call.
go to. Email, call, smoke signal is all good, so we'll get you in touch with Dr. Sakuma.
Can I tell you something that you may or may not know? Um, so one of uh, the reasons that I came to Saybrook was that one of my folk heroes, in a way, actually was a graduate of the PhD program here, and her name is Melanie Joy, and she is now a faculty member at the university. I think it's UMass. I think that's where she is, and she wrote a really amazing book called Why We Love Dogs, Eat Pigs, and Wear Cows. And so, kind of it was a really nice cultural um, discussion about how different cultures they develop rituals and so on that separate us from the animal kingdom, and that the potential problems associated with it. But it's a really great read, and I'm really proud to be at a place where that helped her along her educational path.
Oh, that's fabulous. Thank you for sharing that. Absolutely. Well, we're coming to the end of our time already. It's gone way too fast. Let's do the final two questions that I ask all of my guests. You've heard this before, so now it's your turn, Dr. S. So the classic, what does the term humanistic mean to you?
That's a really interesting question. I haven't heard all of these questions. So we talk a little bit at the faculty, but I don't know all of your secrets. I have heard that you're excellent at this, but what does humanism mean to me? Humanism is a kind of a difficult construct, partly because it lies at a crossroads of two beliefs that seemingly could be contradictory, but I think I've figured out a way to reconcile them. The two beliefs are that there's something very special in us being human, and the second is an anti-speciesist perspective that all species are important and that we have no right to oppress and use other species for our own purposes. And so humanism to me, as I've kind of thought through this paradox, if you will, of like how can humans be special if we're all the same, right? Is that humans are special in that we have special abilities that other animals don't have. We have this amazing ability for empathy, we have this amazing ability for thinking through problems, we have this amazing ability for to make video games and all sorts of, things that only humans can do. And so humanism to me is about potential. It's about it's about the potential of our species and helping people reach that potential um, is kind of how I focus things, because we use this term humane as we've named this thing after the human species, but oftentimes we don't act humanely, and so therefore it's about the potential of it. That's my answer.
Well stated, sir. Well stated. That was really fabulous. I appreciate that. And I liked how you tied in the piece around speciesism. And there's more to come on that topic. I think we need to have a broader conversation on that on here and in our university and what you're doing. So I appreciate you taking a lead in that space. So very much appreciated. So for many of our guests, I've asked each of you to identify three major takeaways of what someone can do right here, right now. Well, maybe not right here, but here and now in their space to take charge of, to improve their mental health, their emotional well-being, to help make the world a better place, to realize their potential.
One piece of advice I would give to people is to to listen more, and to learn how to listen. I think that as somebody who's been in higher ed for 20 something years, I've oftentimes struggled with like what is higher ed? Like what is the purpose of an education? And what I've concluded is that an education is about helping people see that their world is not the world, and that the world expands as we learn from each other. And so ultimately, the way to connect with others' worlds is to listen. That's one thing that I can think of. Another thing I can think of is to find a passion. That's one of the great potentials of the human condition, is that we understand we understand our mortality, we understand our place in time in many ways, and so I think that many of us we have like penchants and we have things that we like, but we don't have passions that drive us. And I think that once you have, like, for example, for me, veganism was something that just made sense to me. It just, this idea that like, why shouldn't we be compassionate to all living beings? And so once people often say, isn't it hard to be vegan? It's not hard when you have a philosophical underpinning to drive you, right? And so I do believe that that is a huge piece that really that can make people's lives better, is to find something that they're passionate about. Doesn't have to be veganism, obviously, but would be great if it were. But that's part of the diversity of the human experience, and it's about finding it, all right, finding that passion. And the third way, I guess, is I'm going to say get involved, and you know, uh, as a clinical psychologist, part of my life is like seeing clients and so on, and so I understand that that what ends up happening is that people are afraid of of reaching out of their bubble, and they become kind of stuck in their own world, and like they stop doing things. And once you stop doing things, there's a stagnation that where people get stuck. And so the way out of that stagnation is to do something. I mean, as an example, people that are working on their dissertation, I can't do it, it's too hard, blah blah blah. If you force yourself to write every day, eventually you're gonna push through it, and 90% of it might be stuff that you edit out, but you will get there by doing things, right? And and so connecting those to the other idea, I think that foot voting is a really important way to kind of get involved. And by what foot voting is doing the things that you support and doing the things that you believe in. And the thing is that I think that the world will be a much better place when we all start. It's hard to care about everything, but there are things that you care about, and if you act that way, it'll all even out. That's my right hemisphere conceptualization of it.
The wisdom of Dr. Sakuma right here. That is pretty fabulous, sir. Thank you so much. Dr. Michael Sakuma, professor here at Saybrook University in our Humanistic Clinical Psychology Department. Really enjoyed meeting you today, sir. It just has been an enriching and very powerful conversation from my perspective. So thank you so much. Where can people find you on the web?
Well, my email address is msakuma at it's msakuma@saybrook.edu. And in terms of a website, I have a website that's ICA Seattle. That's just my clinical website, but I don't think anybody would be looking that up necessarily. But that is a way to me. But certainly drop me a note. I'm happy to chat about anything that we talked about or any other questions that people might have. Like I said, I went out of research and towards clinical because I want to help people, and I want to help people along their journey, and that's another answer to what I'm doing in academia.
Wonderful. Thank you for your time today, Michael.
Thank you so much. It's a privilege to be able to spend time with you.
I want to thank Michael again. I hope you enjoyed Dr. Sakuma as much as I did. Remember his 3 major takeaways. Listen more. Learn how to listen. That's the important piece. And I really thought this was straight spot on. Our world, your world, is not everyone else's world, and learning to listen helps us expand our mind, our worldview, our empathy, all sorts of things. So learn to listen and listen more. Second, find a passion. And third, get involved. Do the foot voting, as he mentioned. Do the things that you support and believe in, and get out there and go do it. If you want to see the video segments that we've created, please visit our Saybrook YouTube page. And if you'd like to support the podcast, go to Apple iTunes and leave that 5-star rating and review, and subscribe so you can get episodes as they come out. If you're on Spotify, leave that 5-star rating and make sure to follow us. You can, of course, subscribe to us on most major podcast platforms, including Google, Stitcher, Pandora, and others. Remember to check our show notes for information on today's guest, Dr. Sakuma, including links to websites, books, etc. For more about our Humanistic Clinical Psychology program or the university, go to www.saybrook.edu, click on Areas of Study at the top of the page, and locate the program to learn more. Or simply go to Saybrook University Humanistic Clinical Psychology program. That's all for now, folks. Thanks so much for joining us. Take care and be well.